We're going to start our big topic of trauma tonight. It's quite a long slideshow. I don't think we're going to get through the whole thing tonight. A good amount of it is review. So we'll be going over some body systems just to set ourselves up, get ourselves primed for the trauma calls, the trauma ideas, how people can get injured, what we're expecting to see, and then also what we can do. So lots of different things to talk about. If you remember from our first lecture, this is kind of where EMS came from, was the need for treating traumatic emergencies, especially similar to what we might see in like a battlefield setting, brought back home to civilians because of cars and all that kind of good stuff. So as we've been continuing on towards these last couple lectures, there is a disclaimer. With this one especially, there's just going to be a lot of images of injuries, so that I can show you what you might see on a call and then recognize what you might have to do. So there will be some blood, there will be some gore. I'll give you a warning before we get to some of the more gory stuff, but don't be ashamed if for some reason you start getting that churning in your stomach. If you want to step away, that's totally fine. Again, I just want to emphasize to you all, not showing these things to you to scare you. I'm not trying to shock you or prove to you that I'm got a stronger stomach than you. Just trying to use it for educational purposes. So that being said, trauma is the leading cause of death in the first half of the age range. It really hasn't changed since the white paper was given to President Johnson in the 60s, saying that the main reason why people die, preventable deaths, is because of traumatic injuries. It's the fourth leading cause of death for all ages. But essentially, if you are old enough to, be alive, walk around, you're more likely to be killed by a traumatic accident than anything else, really. This is the chart of, 10 leading causes of death per age group. This is a little bit old. I should probably get an updated one. This is as of 2018. But as you can see, basically, if you're over the age of 1 here, unintentional injury is the main cause of death until we get into this 45 to 54 year age range, where we start to see other things come up, and especially towards that 65 plus, we see heart disease start to take over. Another important aspect of this is that in the age range of 10 to 44, suicide and homicide are also pretty high up there on the causes of death, which might not be unintentional injuries, but oftentimes they are traumatic. Not every single time, but a lot of times they are. And again, in EMS, when I say the word trauma, we're talking about physical damage to the body, not to the mind. So this is just something interesting to look at in general, just to see what the most common reasons are why people die. For our purposes tonight, it's really going to be focusing on this unintentional injury aspect, the traumatic accident. So before we get into the injuries themselves, I do just want to do a quick review of some of the body systems that are going to be affected. So first off, we got the skeletal system. Like we talked about on Saturday with splinting, this is really what we're trying to get down to understand, is the structure of the body. Combined with those head-to-toe trauma assessments that we do, really what we're trying to feel and we're trying to figure out with those trauma assessments is the skeleton under somebody's skin and muscle, is it still intact? We'll be able to feel it if it isn't, or the patient will be able to let us know or reflect the pain that they're experiencing when we palpate an area that is damaged. Not every single broken bone is going to be a life-threatening injury. Really, if somebody has a broken arm, broken leg, like we talk about with secondary injuries, I'm not super concerned that their life is in danger. However, if it's a widespread trauma, if they've got lots of broken bones, if their rib cages are broken in certain ways, if their pelvis, their femurs, those are some of those injuries that could also be life-threatening. Specifically, when we talk about the spinal column, right, we're going to be putting a lot of our focus and a lot of our effort treating people who have been in a traumatic accident. We're going to put a lot of effort into stabilizing their spine and moving them in ways that aren't going to agitate or, make worse an injury that might be in their spinal column. Our purpose is that cervical spine, lots of emphasis there for us with those cervical collars, but then also how we're going to move people and using manual stabilization, holding that C-spine during trauma. The cervical spine is the most important part of our spine for somebody to stay alive. If there's an injury there, the chances of their diaphragm stop moving, their breathing, faltering, their heart rate, all that kind of stuff is just going to go down the drain. So last thing we want is for somebody to have a cervical spine injury, also like traumatic brain injuries and stuff. And the further down it gets, it's still concerning. There's still going to be a lot of potential issues here, but we can't really put a whole entire brace on the rest of the spine. That's why we keep people supine, use our stretchers. But the cervical spine, we're going to have to take extra care to make sure that we're protecting. Within that skeletal system, the thorax or chest is where we really don't want to see trauma as well. If we're outside of the spinal cord, this is the area in which some of the more important organs we have in our thorax are: our lungs, our heart, right, our diaphragm, really, or anything protected by these ribs. If it's damaged, it could lead to a bad time for our patient. So keeping in mind that those ribs are there as sort of like a natural armor protecting the things that we really need to have protected. So any kind of damage, whether it's blunt or penetrating trauma to this area, could lead to some really negative side effects. Penetrating injuries we'll talk about with, like sucking chest wounds, and blunt injuries we'll talk about with the flail chests, the paradoxical movement. All of those things are life-threatening conditions, life-threatening injuries that we're going to have to recognize and then also potentially treat. There's also some really big blood vessels that run through our chest, typically like along the spine, really deep in there. We've got our big aorta and our vena cava, the big arteries that bring blood away from our heart down to our lower half, and then also bring it back into our heart. So penetrating injuries that might reach those arteries deep down in there, that could be really bad. All of this to come back and say that perfusion, the idea in the process of our heart circulating blood out to our internal organs, every single tissue inside our body, this is the most important thing that somebody needs in the event of being sick or injured. All of you are perfusing really well right now. If you weren't, you'd be feeling it. And this is what we're trying to essentially keep our patient doing. If there's an injury that's getting in the way of the body's ability to perfuse oxygen-rich blood out to our internal organs, that's when we start to see people go into shock, because that's hypoperfusion. Low perfusion, not enough to essentially supply the tissues and organs with that oxygen and those other nutrients. The heart, while it is the main organ behind pumping the blood out to create the pressure and get the perfusion out to the lower areas of our body, the distal areas of our body, it also has its own perfusion that it needs. So if we're talking about like a heart attack, the heart isn't getting the oxygen it needs, it's not perfusing that blood, or it's not getting the perfusion of it. And so when we have this idea for trauma, it's typically that the heart is either working overtime and blood is leaving the body. There's an injury, and so the heart's pumping, but unknowingly it's pumping the blood out of the body, losing its supply, and so eventually it's going to run out of liquid to circulate. But then it also, if the heart is stopped due to traumatic incident, blood pooling inside the sac around the heart, or physically just being damaged, that's definitely going to lead to a lack of perfusion. We really just need to keep this going. The brain and spinal cord can only survive without oxygen, without perfusion for about 6 minutes before they start to exponentially die. We talked about that when we were talking about cardiac arrest. And then other internal organs, they might be able to last a little bit longer without perfusion, but not the heart, not the most important things that keep people alive. So in general, when we're talking about trauma, we just want to preserve this perfusion. We're trying to support their body as best we can to keep the blood circulating, keep the heart working, keep oxygen moving. Without that oxygen in this system, without the blood flow circulating through the body, every internal organ, every tissue, every cell that we have is going to start to struggle. We do have some anaerobic processes that we can do. Our body can still function a little bit without oxygen, but the longer it has to do that, the worse off we're going to be. So when we're doing shock treatment, and we're going to spend a good amount of time talking in more detail about shock towards the end of this presentation, this is really what we're just trying to prevent. We can't stop somebody from going into shock or compensating. We don't really actually want to stop them from compensating. We probably won't be able to. What we're trying to do is we're trying to make it easier for their body to compensate for longer. We're just EMTs. We don't have surgery capabilities in the field. Even paramedics don't. We can't just open up an OR and give this person the surgery that they need to fix the internal problems. But what we can do is take some of that pressure off of their internal systems to make it so they can stay alive for longer. Circulatory system is incredibly important when we're talking about trauma. When we see any sort of bleeding, that is a circulation issue. For relating back to our ABCs, our airway, our breathing, and our circulation, this is one of those big ones. Like we were talking a little bit about on Saturday doing trauma assessments, is that the reason why we're going to stop as soon as we see any sort of bleeding and immediately tend to it is because any time spent doing any sort of other assessment or other treatment is really going to be wasted if that person is still losing blood. If they've got a really bad arterial bleed, seconds really matter. Somebody can, pump out most of their blood in a couple minutes if they have a really severe injury. So bleeding is always going to be one of our first steps to ensuring that we can help treat somebody. So understanding how the blood gets around, the difference between those veins and those arteries, how they bleed is also going to be really important. Reason why blood is so important is that it provides all of our tissues and our organs with everything that it needs. It is the communication besides our nervous system. It has, our immune protection in it. It's got our immune system with those white blood cells. It's got our anti-bleeding system with those platelets. It's got our oxygen transmission system with the red blood cells. And it's got our hydration, our plasma that circulates around everywhere. So a lot of what we need to just stay alive constantly is in our blood. And if we don't have that blood, we're not going to be able to stay alive. Now, there are some capabilities with ALS being able to, bolster the amount of fluid in somebody's circulatory system. If somebody bled a lot and we control that bleeding, EMTs and paramedics, we could give some saline. We can give them a fluid bolus, essentially some salty water into their veins and their arteries to bolster this. However, we can only do so much because saline doesn't transmit like red blood cells. It doesn't have platelets in it. It doesn't have any of the actual blood components. So if we put too much in, essentially we've just created another problem where we've made Kool-Aid instead of supporting their blood system. So that's just things to think about as well. We can do some bolstering. We can get their blood pressure up a little bit to reduce the work on their heart, but we can't completely replace it because we don't carry blood on the ambulance. That might be changing, and I don't know how soon, but I know that there have been studies where ambulances, paramedics have had blood stored on their ambulance for replacements and transfusions if people need it. However, it's really expensive to do. You've got to be able to store blood on the rig for an extended period of time, and also you have to be able to get whole blood, which is pretty challenging. Again, in this section of review, the arteries are those big, high-pressure vessels that carry oxygenated blood away from the heart, for the most part, and then veins are these smaller, less high-pressure vessels that return oxygen-depleted blood to the heart. Capillaries are the really tiny connections between the two, pretty much microscopic, where that oxygen exchange happens when it gets to the cells, to the organs. So that's why we use capillaries a lot to determine how well somebody is perfusing, because if somebody is not getting good capillary response, we know that their blood pressure is low. So if we do that cap refill test, where you look at the back of your nail, you press on it, it should go from your normal skin tone to like a lighter skin tone, and when you release, you'll see it slowly get darker as the capillaries refill with blood. If it's longer than 2 seconds, that means that somebody's circulation is diminished, their perfusion is diminished. It should take about 2 seconds for it to go back to its normal shade. So a really quick assessment to see if somebody's perfusing well is just do a capillary refills check. Pinch their finger, look at their nail, and if it comes back really quickly, great. If it comes back nice and slowly, then you know that something is going on. Now, our body is actually pretty good at getting hurt. We've, developed over millions of years to essentially have some capabilities to help ourselves without really doing anything, without really first aid knowledge. So if you've gotten a paper cut in your life and you haven't spent the time to hold good direct pressure, it'll stop bleeding in a couple minutes, right? For the most part, healthy people can stop their own bleeding to a point, not really if it's an arterial bleed or a really bad injury, but in general, if you get a little cut, if you cut yourself while shaving or whatever, you don't really have to do much. Your body's own processes, those platelets are going to clot and stop that blood from exiting your body. They're going to form those scabs. Now, we're EMS, so we're going to see patients with all sorts of different conditions, all sorts of different medications, and there are quite a few popular and quite widely prescribed medications for other conditions that could lead to anti-clotting factors. Things like Coumadin, right, for blood thinners and stuff. Some of those drugs are really, really strong and pretty much knock out somebody's ability to make clots. Typically, those are prescribed for people who are at risk of strokes or heart attacks to reduce clotting so that they won't build any of those clots in those important arteries. And then there are also genetic conditions like hemophilia that somebody is born without this ability to clot their own blood. So really, if somebody on Coumadin or somebody with hemophilia gets a small cut, it's just going to bleed almost incessantly unless they get a lot of help. So we need to be aware of this. If you're treating somebody elderly or somebody who is prescribed Coumadin and they take it regularly and they have an injury, it's probably going to be harder to stop their bleeding than if they weren't taking that medication. We also see increased risk of internal bleeding with patients who are taking those medications, because if they fall and hit their head or just fall in general and break a bone, they might be bleeding internally for quite a while, developing a stroke or just losing all their blood internally. That's just a really gross blood clot came out of somebody's nose. If you've ever had a big bloody nose and you just you pinch it for a while and then you stop and you blow out a big clot, it's really gross. But shows you how our blood works, shows you how our body treats itself. All right, so on to that idea of types of bleeding. The type of vessel that is damaged is incredibly important for us to try to recognize. It might not be as easy as you think. While we do talk about arterial bleeds being squirting blood, it's kind of one of the only things that majority of media gets right about EMS and medicine and injuries, is that if an artery is damaged, you will see a spray of blood, squirting blood out of that injury in time with somebody's heartbeat. Because of how high pressure those vessels are, how they're directly connected to our heart and how it's pushing it out with every beat, when somebody gets injured, you can see blood spraying out of that arterial injury. Now, that only happens while the blood pressure is essentially high enough and there's enough blood in somebody's system to do that. So unless we're really close to being on scene a few minutes after that injury happens, we're actually not really likely to see squirting blood because somebody might have been bleeding for a while before we got there. And they're essentially have lost the pressure to be able to spray out of that injury, but we might still see blood leaving at a quick pace. One of the big flags to recognize between arterial and venous bleeding is the color of the blood. Arterial blood will be really bright red, almost like neon hot red. And that's just because oxygen is in it and it's oxidized and it's just really bright red. Venous blood is going to be more of that classical blood red color that you think. It's going to be that dark kind of burgundy, just a lot darker of a shade of blood because there's no oxygen in it. You may have heard, like I heard this rumor a bunch of times. They're like, oh, did you know that your blood is actually blue inside your body? That's not true. Your veins just look a little bit blue, but they're not. The venous blood is just going to be darker red, more of that burgundy. And it's not going to come out of somebody as quickly as an arterial bleed would. There's not as much pressure, right? And if somebody has a large slash or something, you can be a really big issue, but you're not going to really see spraying or squirting from venous wounds. You're going to see a dark, steady flow. It's going to be like oozing or pouring out rather than spraying or just dumping. Now, capillaries, very few capillary injuries could cause like a life-threatening bleed. This is really what you're going to see with a superficial wound. So like a paper cut or just a standard not very deep cut on a hand, on an arm, whatever. If it's shallow, it's probably not a vein unless it hits a vein directly, but just a small cut that bleeds is probably capillary blood. The other common place that we see this is on like the head and face. Head wounds that aren't like down into the skull or anything like that, they're not traumatic brain injuries, they can bleed a lot because essentially all the blood vessels we have visible like on our head it's pretty much capillary. So that's why like little lacerations to the forehead, to the scalp, to the face, they tend to bleed a lot, but it's just because there's just a high concentration of capillaries. We do want to stop that bleeding. Any bleeding we want to control, but they're less likely to bleed out or go into shock from a capillary injury. Humans, like, depending on their size is what really matters. Here's another one of those portions where it's like, oh, here's a very generalized milliliter count or liter count of how much people can lose. But, you know, there are kids who are bigger, so this is just kind of an estimation. Adults, we roughly say that we can lose about a liter of blood, up to a liter of blood before it's like a really dangerous situation. To put it in a little bit of perspective, that's basically a Nalgene bottle full, up to that 1 liter line, or half of like a 2-liter soda. So anywhere up to around 1 liter for a full-grown adult is going to be bad. Once we hit that liter mark, it's pretty much impossible to get somebody back unless we get them to the hospital and get them a big transfusion of blood. Kids, we say, are typically around 500, around half that. And then as we get down to infants, it's even smaller, 100 to 200 mils. It's going to be tricky for us to actually determine how much blood somebody lost. The last thing I'm going to tell you to do is actually try to go and like measure how much blood somebody lost. I'm not going to have you bring a Nalgene around and like try to scrape whatever blood you see into it to get an idea. We can't even really estimate it very well either. So I'm going to give you an example. How much blood would you estimate is in that puddle? Let me pull up chat. Just give it a guess. Give it a whirl. 5 milliliters. Okay. Anybody else?
I guess a cup.
A cup? Okay. Real question here for you. Do you think it's more or less than this amount of blood?
It might be more because of the carpet, like it sunk in.
Yeah.
Potentially.
I would wager.
For sure.
I like what. No, you're exactly on the right track. The carpet and the tile. So the area or the surface in which somebody is bleeding is going to make this a little bit more challenging. I would wager this is about the same amount of blood. However, one is on carpet, so when the liquid landed, it soaks down. We have volume involved. Versus on a tile or like a hard wood or a stone floor, it's going to spread out. It's going to be thinner, but it's just going to look like more. So all of this really to say, when we kind of estimate how much blood somebody has lost, it's going to be more along the lines of like, oh yeah, it was a good amount versus, no, that's a lot of blood, right? It's going to play a big part of it when you walk onto scene, because we can't really do this when we practice in lab unless we, get covered in fake blood. But there's the assessment aspect of walking onto scene and seeing a lot of blood or a little bit of blood. If somebody's got an injury, they're bleeding, you walk onto scene and you see a little bit of blood around, you say, okay, did you bleed anywhere else? Like, do we have to go look for it? But you're going to be able to say, yeah, it didn't look like that much blood. Versus you walk on scene, you see somebody sitting in a pool of their own blood, or you walk into the room and you can see like the pathway that they walked since they've been injured, dripping blood, pools of it in different places, large volumes. That's really what we're worried about. So you can do basically this scale. Did they lose a little bit of blood? Did they lose a good amount of blood? Or did they lose a lot? That's kind of what we're going after. Any large volume of blood lost is a huge concern for us. We can't truly measure how much somebody has bled. We can't really verify that. So essentially, we just need to stop that bleeding and be very watchful and assessful. I guess that's not really a word, but we need to be assessing for signs of shock, signs of that bleeding loss affecting their perfusion, their body. Another aspect of bleeding, though, is the fact that it might not be external. We might not be able to see their bleeding. A lot of our body, while it looks kind of solid, we have a lot of empty space, especially in our abdomen, our pelvis, and our thighs. There's a lot of area that blood and other fluids can kind of pool into. So it might not be readily apparent that somebody has suffered a major bleed after a traumatic accident, and we need to be looking for signs of it. The mechanism of injury is also really key during this phase. These are the times that can kind of confuse us and can get by providers. The one that I'm thinking of specifically is one of my good friends went on a call where somebody was driving on the highway going about 75 miles per hour, and they crashed right into another car. They were going about 70 when they rear-ended another car, and when they got there, they were surprised that they didn't seem very hurt. Airbags went off, all that stuff. They were wearing a seatbelt. They didn't really have any external injuries. They just had a big bruise on their chest and their abdomen. They wore their seatbelt a little high on their abdomen, and they were just complaining of just like pain around those areas. And they were having a conversation with the crew. They didn't really want to go to the hospital. They said, I just have a bruise, my neck doesn't hurt, nothing is really bothering me. I don't really want to go. But this crew was smart, and they said, I really think you should come get checked out because the mechanism of that injury, you were going 75 and now you're to a sudden stop. That's not good. There might be some internal injuries. And they were absolutely right, because as they were transporting that patient, she started to really quickly decline. And it turned out she was having some major internal bleeding from that seatbelt. Essentially damaged some internal organs. Wasn't readily apparent. She was feeling okay for the first 10-15 minutes after that accident, but it was because her body was compensating and it hadn't lost that much blood, and they weren't able to assess it. You can lose about a liter of blood, that deadly level, into your thigh before there's any swelling. It can be really tricky to assess for internal bleeding. So what we're looking for is things like this discoloration. Right, it's kind of like a bruise, but it's more likened to lividity, dependent lividity, when somebody is dead and their blood is starting to pool in the lowest point of gravity. So it's gonna be like that. You can see that it almost looks like liquid under a fabric or a piece of plastic, and then especially over here with this guy, you can see the distension of his abdomen. Usually, even with people who are a little bit more overweight, there's usually a pretty clear distinction between their abdomen and when we get down to their pelvis. But this just looks like a balloon, right? It is swollen. There is a lot of discoloration, and clearly this patient was in a severe accident. So other things to look for is rigidity, which means if you feel like your arm right now, there's probably going to be a good squish to it, right? Even if you got good muscles, you're going to have some squish to it. Whereas rigidity means it's going to feel solid. Like the skin is going to feel extended and swollen, and it's going to be harder for you to actually touch and palpate it. So those are really signs that are indicative of internal bleeding. This is also internal bleeding outside of body systems. internal bleeding can also take place inside body systems. So these are some examples of both. Ecchymosis, that is just the medical term for bruising. So if you ever want to feel cool at a dinner party, break out that term. A hematoma, this is when there's bleeding beneath the skin. It's similar to bruising, but we see more along the lines of like a swelling kind of welt show up along with the discoloration. Hematoemesis, this is blood in vomit, so indicative that somebody is bleeding in either their stomach, their esophagus, or their upper airway. Hematochezia, this is blood in somebody's stool, so somebody is passing blood, they're pooping it. One of the big distinctions here that we need to talk about is the difference between hematochezia and melena, because it's really going to play into where they are bleeding. If somebody has red blood in their stool, that tells us they are bleeding in a lower portion of their GI tract. They're bleeding somewhere in their intestines, typically towards the bottom. If we see melena, which is black, tarry stool, it really just looks like coffee grounds. Like if you take out the coffee filter and you dump those used grounds somewhere, that's what it looks like. And that is digested blood. So melena would tell us that somebody is bleeding probably like in their stomach or upper intestinal area, because we're seeing the blood being digested as it makes its way out. And if they're passing like dark, black, tarry stool, that often means that they're bleeding a lot and it's just being digested. Whereas red bloody stool tells us that it's towards the bottom. No pun intended. This is bad. It's really hard to control internal bleeding, especially in the GI tract. This can kill a lot of people and it can kind of come out of nowhere. So really, if anybody is passing red blood, check if they've had beets first. This is also one of the more common calls that we get, is somebody thinking that they are bleeding out internally when they just eat a lot of beets. It can turn your waist pretty red. But if somebody is truly bleeding, that's really bad. We don't know how long they could have been bleeding for. They can be bleeding quite a bit before they actually have the urge to pass it. So GI bleeds, really gross, but also really deadly. So we need to take them very seriously. I'm not kidding that it really just looks like coffee grounds. It's crazy how similar they look. And it's just a bad sign. Some other ones. Hemoptysis. This is coughing up blood, so that would tell us that somebody is bleeding like in their airway. Could be in their lungs, could be in their trachea. It could also be like in the back of their throat. If we think about it, we just don't really know where. If we can't assess or see any open wounds or bleeding in their airway, we have to assume it's a little bit further down. Some physical signs or reactive signs from the patient is going to be like the tenderness or the guarding. If somebody is subconsciously like preparing themselves for you to assess an area, that just tells you that they have pain there, even if they don't necessarily recognize it. So if you're like going down to palpate the abdomen, and before you even touch a spot, you see them like get ready to guard or just like tense up a little bit, that tells us that they're preparing to experience pain. And then of course, swelling, bruising over areas can also indicate internal bleeding. And then that rigid, that distended abdomen, that's a really important part. That's what we're going to be feeling for in our trauma assessments when we're doing those abdominal assessments is, do we feel any rigidity? Do we feel like a pocket of fluid or an area of the abdomen that feels more solid than others? That's definitely going to be a sign of internal bleeding. Okay, now we're getting on to the trauma stuff. So it's not just enough to talk about trauma itself. We have to talk about the different types of trauma. There are really only 4. The first 2 are going to be the most common types that we see, but blast and barotrauma do exist, and we need to be prepared for them. So blunt trauma, this is anything like a large object hitting somebody with force, typically having a wider area of impact. That's kind of what anything moving fast enough could technically impale somebody. But when we're talking about trauma, it's usually a wider surface area of impact that spreads it out and just breaks bones, damages skin, maybe damages internal organs, but it's not anything penetrating into somebody. So, a car striking a pedestrian, that would be blunt trauma. Getting hit by a baseball bat, falling or being struck by a falling object. Anything that strikes and damages the body. Penetrating trauma, that is anything that goes into the body forcefully. So stabbings, impalement from really any object that can be moving at such speed to go into you. So gunshot wounds specifically, these are huge examples of penetrating trauma. It's really anything that forces its way inside somebody where it's not supposed to be. Now, blast trauma, this is just trauma resulting from explosions. There are a couple different areas of effect when we talk about blast trauma. And one of those areas of effect is barotrauma. So rapid, or trauma resulting from a rapid change in pressure. So if somebody is really close to the explosion, a lot of times what happens is the air pressure changes very quickly. And so organs like our bladder, more like balloon type organs or hollow organs can really get damaged from that rapid change in air pressure to the point where they might be, destroyed or really badly ruptured, like a spleen or something like that, the lungs. So we might not see external injuries, but we might see signs of internal injuries from just like a high pressure change. This is not so much something we have to worry about when we're talking about like change in pressure from like scuba diving. In Vermont, I don't think Lake Champlain is deep enough for there to be a concern with that. But if you ever want to work in a place by the ocean, you might be dealing with somebody having barotrauma coming up from deep under the ocean where the pressure is different. All right, let's talk about MVCs. Motor vehicle crashes. These are a big part of our job. Again, motor vehicle crashes, probably the biggest reason why EMS exists the way that it does these days. And when we're looking at these motor vehicle crashes, it's not enough just to see that a car has been damaged. We also need to think about how it was damaged, in what direction were they going, what direction was the thing that hit them, was it another car? Did they come to a complete stop at the tree? Whatever it is, we need to have an idea of what injuries we might see. This is part of our assessing that mechanism of injury. So there's a couple different types of impact. We've got a frontal impact, which is where essentially something strikes the car from the front. Rear impact, which is the opposite. Lateral impact, which would be like a T-bone coming from the side, right? It's 2D, so I could only do this so well. It's not coming up from underneath the car. It's coming at the car from the side. And then a rotational impact is hard to exactly tell, but it's where somebody spins, the car flips and rolls, whatever it is. There's quite a few different areas of impact here. This is important for us because the types of injuries we're going to see can really depend on the type of impact that somebody was in. If somebody was in a frontal impact, know anything about Newton, right? The car is driving forward. There was an impact here. So this person is going to keep going forward, right? The person in the vehicle, they're going to continue forward because that's the momentum that they had. Meaning if someone's in a frontal impact, we're likely to see injuries where somebody is thrown forward either into the steering wheel, against their seatbelt, or into the windshield. Whereas in a rear impact, somebody is struck from behind, we're likely to see injuries consistent with them going backwards and then potentially forwards. Lateral impact, same thing, into the side, their window, right? Or if they were sitting on the side where the car struck them, we're likely to see damage directly to them if that vehicle is going fast enough. And then rotational impact, somebody being thrown around inside a moving vehicle as it tumbles, or other objects in that car becoming projectiles and damaging somebody because they're being thrown around. The other thing to consider is that if you're seeing an accident or a crash that has more than one car, you're also likely seeing different types of impact, right? If we've got somebody who goes to a stop sign, the person behind them is on their phone texting or whatever, crashes into them, we're going to see two different types of impact here, right? We have the person in the car who struck the other car is going to have that frontal impact. We're going to see them potentially go forward, whereas the patient in the front is going to have rear impact potential injuries. So, I'm not telling you this stuff so that you go to a scene and just like you're taking notes. Oh, front impact, blah, 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 rotational impact. It's not like an assessment that you need to document like that. It's one of those things where you just should be expecting certain types of injuries. Remember that mechanism of injury, however severe that it looks, is giving us this suspicion of injury. With how badly damaged that we see their car, with the type of impacts do we see, how suspicious are we that the person that we're going to be treating is severely injured? That's what we're getting at. Really trust your gut, because you show up, you see a car damaged, high mechanism injury, I'm really suspicious here. I'm worried about that person. I think they are injured. And if they crawl out of the car and they seem uninjured, we really want to be emphasizing that they should probably get checked out at the hospital, because the mechanism was high enough where they could have internal injuries that they're not really recognizing at this time. So here are some other indications of severity in a crash. Airbag deployment. Cars have very sensitive but specific monitors for these airbags. If they are deployed, it means that there was enough impact to trigger them. Essentially, they've done a bunch of research and determined at a certain level of G-force impact, somebody needs an airbag deployed. Now, the other thing for us to consider, just on a sidebar here with airbags, is if we arrive at a motor vehicle crash and we don't see airbags deployed, we want to ensure that the fire department takes care of this vehicle before we go in. If you're watching this little video down here, airbags leave their casing really quickly, and they are specifically timed to catch somebody who's going into them. But if you are by an airbag when it goes off, it can be deadly. All right. These areas, especially these front airbags, the passenger seat and the driver's seat, we're in this area a lot during a car accident. Somebody's in that driver's seat and they're sitting there, we might be leaning over them with our head right next to the steering wheel. If the car was in a crash and the airbag did not deploy, it is very important that we have the fire department come and disconnect and make safe this car before we go into it. Because if there was a crash, like, it could be that the airbags didn't function properly, and if we get our head right next to that thing, it could be very dangerous. All right, so it's an indication for how severe the injury of the patient might be, but it's also an indication for safety for us. If the airbags have not been deployed and the fire department's not there yet, we want to be very cautious. We probably don't want to go into that car. If we can, have the patient come out, and if you have to be near the vehicle or in the vehicle, just be very cautious. Keep your head away from where these airbags could be. Another indication of severity is what we call windshield spidering. Looks like this, right? Like a spider web of cracks in the windshield. Another big indicator here is that somebody hit their head on the windshield, right? With this type of glass in car windshields, you're probably not going to be able to feel like the crack on the outside if somebody broke it on the inside. So if you see a point and the cracks come out from there, typically you're probably going to see it over where somebody's head would be, either in the passenger seat or the driver's seat. This indicates that they struck their head on the windshield with enough force to crack it, which is not good. Another thing that's really bad to see is intrusion into the cab. So essentially deformation of the car's structure, and it's become misshapen to the point where it could be pressing on, crushing, or impeding our patient. So you can see here in this test dummy image, right, that dummy's legs are right in the pedal wheel, or not the pedal wheel, where the pedals are, sorry. And when it crashes, the car scrunches up, and so now where the pedals were is now part of the engine block, and those legs are probably broken, crushed, or damaged. So if we see the area in which the patient is sitting has gotten smaller, big pieces of metal or parts of the structure of the car are twisted and crunched into that area, it's a bad sign. It's likely that they probably have some injuries. There was a call probably 10 years ago in the area where unfortunately like a group of college students were coming back from skiing. It was late at night and their driver fell asleep and went off the road, crashed into a tree. And I remember hearing about this because one of the paramedics that I worked with was on that call. And this is one of the only times they've had to call and ask for consideration for an infield amputation. They didn't end up having to do it, but the driver's legs were essentially so pinned inside the vehicle that they were worried they weren't going to be able to get them out in time to save their life. And so they called and were discussing with doctors the potential of removing that person's legs so they could get them out of the vehicle. As far as I'm aware, they were able to do it without amputation, but it's one of those things really scary. Somebody was completely trapped in the car because the car had closed itself around their legs. Very bad day. Another really important thing is seatbelt usage. I know it's one of those things you're told your entire life, and I'm sure some of you might not drive with your seatbelts on. As an EMT, stupid thing to do, always wear a seatbelt. Let's watch this video. This woman right here is not wearing a seatbelt. This one is. All right, it's on repeat, so you're going to see it again. Watch how much more this woman flies around than this woman and see where she hits herself, right? This woman went right into this airbag, was kept in place by her seatbelt, and was relatively okay. Right, you can see her holding her neck. It's not going to be pleasant. She's still potentially injured. But this woman went across and then back again. Right? She hit her head on a couple different things and was thrown into the vehicle. All right? Very important to wear your seatbelt. This is also one of those things to assess for, right? Were you wearing your seatbelt? Because that can make a huge difference in the number of injuries that somebody has or the severity, right? One of the reasons why I got into EMS was because one of my good friends in high school was in the backseat of the car on the way to school, not wearing a seatbelt. The car went off the road and he died, right? It's just one of those things. It can happen very quickly without really thinking about it. One morning you're just sitting in the back seat between your two friends as you're driving to school, wanting to see up through the window with them, and then bang, you go off the road and that's the end. So wear your seatbelt. The other thing that's important is the speed of impact. Right? How quickly was somebody going? These two women, this driver looks like a taxi or whatever. They weren't driving very quickly, but you can tell that the person who hit them was because of how much force was exerted. We can also see things like this, right? Here's an example of potential spidering, right? It didn't happen, but that's what's going on, right? Not wearing a seatbelt, frontal impact, got thrown over the steering wheel, and bang, they're unconscious after they slammed their head on the windshield. Here's a little bit more dramatic example. Or like that, right? Older vehicles, you can basically see the pole go all the way through the front of this car. The airbag's deployed, but still, that car was going fast. Not a good day to be that person. Here's an example of like a rear impact. I can guarantee you that person was texting or distracted. You can see them try to brake towards the last minute. You can see their car go down, but the road's wet. They were going way too fast and they weren't paying attention. The other thing dangerous here is right at the back of that truck going through the windshield of the striking car. And this one's just kind of funny. Okay. So common injuries that we see in either drivers or passengers inside these vehicles, classic head, neck, or back injuries. There is a lot of that forward momentum, the side to side that's not good for a spine. If you just like quickly do it, right, it can cause step-offs, breaks, damage to the spinal cord. Along with this idea, we've got something called coup and contra coup. It's a thing we need to start thinking about. It's interesting. Because what we tend to see is that especially with head injuries, especially in frontal impacts and rear impact crashes, we tend to see brain injuries and pain presenting on somebody in the opposite part of their head in which they were hurt. So coup would be somebody struck in the front of their head, their brain is going to go forward, but then the most amount of momentum it gets is when it sloshes back, right? So if there's an impact on the front, it goes forward, but then the whiplash of the brain hitting the back of the skull is what's going to cause most of the injury. So if somebody gets hit in the front of the head, they're likely going to be reporting pain in the back of their head and vice versa. If they get hit in the back of the head, they're probably going to have pain in the front. And it's just kind of a testament to the liquidity, the gelness of our brain and how it's suspended in liquid. So when it goes one direction, it's going to go back the other direction much more quickly. We also see quite a few chest injuries. This is a lot of times from the seatbelt, but then also like intrusion into the cab, or if they're thrown into the steering wheel. Those can cause a lot of broken ribs. That's a lot of times where you can see flail chests and stuff. It's because somebody's thrown into the steering wheel and they break a big portion of their ribs. Extremity injuries are also very common. A lot of times legs, right? Another thing you do not want to do is be a passenger princess riding with your feet up on the dashboard, because if you get in a car accident, guess what? You're going to look like a flamingo. Your legs bend back the other way. So we do tend to see a lot of leg injuries. And then also internal bleeding, like in the example I shared earlier, where this quick and high force of trauma can cause internal damage that might not reflect externally. Damage to the spleen, damage to internal vessels, arteries, things like that. Now, cars versus a person. There's two impacts here that we have to be aware of, is that there's likely going to be injury from where somebody was struck by the vehicle, but then also where they struck the ground. We're likely to see more abrasions or things after the fact, but a lot of like head injuries, neck back injuries, chest and extremities. You're more likely to have lower extremity injuries if you are dealing with like a sedan or a sports car. If you're walking and the car takes your legs out or strikes your legs, you fall onto the windshield and you're less likely to have head injuries or chest injuries. Whereas if you're struck by a big truck or a van or something like that, that's more of like a straight on versus getting your legs taken out. So we likely see a lot of head, neck, back, chest, extremity injuries. Okay. Any questions about motor vehicle crashes? Okay. Falls. After car accidents, honestly, these are probably the most common types of trauma that you might see, and it's usually in the more elderly populations. When we talk about like mechanism of injuries, anybody who is over the age of 65, if they have a standing height fall, a fall from the height at which they stand, that is automatically considered a life-threatening situation. They could easily suffer an injury that ends their life or severely, impacts it from a standing height fall. Whereas somebody who is 29, like me, is likely not to get a life-threatening injury if I fell. Yeah, I'm tall, I'm 6'3", but if I fell, I'm more likely to break a bone than I am to die. Whereas a lot of people over the age of 65, right, if they fall, they can break their hip, bleed out internally, break a femur, hit their head, have a hemorrhagic stroke. All bad things, right? That's why there's Life Alert. Help, I've fallen and I can't get up. That commercial, right, it's kind of silly, but very true. A big impact in our elderly population is somebody falling, unable to get up, unable to get help, and being left in a really bad way, potentially even dying on the floor because they weren't able to move. So we need to be considerate of how high they fell from. We also want to be considerate of the surface they landed on and the age of the person. A standing height fall onto any surface on somebody the age of 65, I am very concerned. Anything above like a 20-foot fall for somebody under the age of 65 is when we can start to consider it like a really deadly situation. So that's like a 2-story. That's when we start to see more consistent life-threatening injuries. Again, if you fall onto grass or into a ball pit, it's going to be different than if you land on gravel or concrete. And the other thing we need to consider with falls is where somebody struck the ground might not be where they have injuries. So we can see in this picture here, if this girl jumped from that tree and landed on her heels, we might not even see damage in the heels, but what we're going to see is potentially a back injury or a neck injury or a hip injury, because they land on their heels and the force of that goes up their legs into their hips, into their back, where more compression injuries are likely. They might have like a small hairline fracture or even a broken foot, but probably the biggest amount of pain they might be reporting is in an area at the other end of the force. So not everybody falls directly onto their heels. If you fall onto your side, it might be hurting the other side of your body. But we just have to recognize that force will travel, especially if somebody's falling from a great height. Okay, here we go. Here's some of the pictures. And an acronym for you. So this one, DCAP BTLS. This is to help us remember what we're looking for when we're doing our traumatic assessments. When we're doing those head-to-toe trauma assessments, these are really the injuries we're going to be able to find, or at least this is a list which we're able to roughly condense everything into. So deformity, the first one. This is really just anything that doesn't look right. Right? This image, granted, isn't from an active injury. It could be like a genetic thing. It could be, something he's grown up with, but it could also have been that he broke that femur a long time ago and just never got really good healing for it. So it's just a great example of, if you show up, you see somebody who's supposed to look symmetrical after an accident, and you see a deformity, something that is clearly out of place, pretty good indication that something is broken. Now, a contusion, just another fancy word for bruise. It's just that discoloration, that darkness. If it's getting lighter, it's probably healing, right? You can see some of that kind of like greenish yellow color in there. It means you probably got that bruise a while ago and it's clearing up, but that's a pretty big bruise. Immediately after somebody gets struck with something really hard, you're probably going to see bruises start to form. So if you're doing that assessment and you see a contusion, there's likely an injury under there. It could also indicate like broken bone underneath or internal bleeding. Now, A is for two different ones. It's either an abrasion or avulsion. An abrasion is rug burn, right? Up to road burn or anything really that is removed off by force. Whereas, this is gross, an avulsion is skin, a flap of skin being pulled away from where it's supposed to be. Still attached, but flapped. Puncture, right? Anything that is inside the body that's not supposed to be. It could be an impalement, but it's just punctured into the skin. I think this is either a knee or an elbow that has like a bar dart in it. So not life-threatening or anything like that, but definitely painful. Burns, definitely a worrisome thing when it comes to trauma. This can lead to a lot of issues down the road. More often than not, people with severe burns don't end up dying from trauma. They end up dying from issues with the burns afterwards. Infections, hypo or hyperthermia. We're going to talk a little bit about burns today, but then in our environmental lecture, we do a little bit more of a deep dive. Tenderness, honestly, this one's kind of like the lame one out of this acronym, where it's just kind of like everything is like, oh, I've got an avulsion, oh, I've got a puncture wound, then it's just like, oh, my, kind of hurts, right? It's just any sign that somebody has a reaction to pain, right? Oh, yeah, when you palpate there, it hurts. Tenderness on palpation, or somebody just being like, yeah, my shoulder's in pain, right? It hurts. That's just kind of the idea of tenderness. Lacerations, this is basically something slicing the skin. It could be down pretty deep too, it could be pretty shallow, but essentially anything that cuts smoothly through our skin tissue. And then swelling, right? If you can see it in this image, one of the good ways to assess for swelling is compare the injured extremity against the non-injured one. So you can see that this is the non-injured extremity. You can see the definition of the muscles and stuff, but on this one it is clearly bright red. It's probably hot to the touch, and it's swollen. You can see that it's a little bit more puffy than the other side. So there's likely an injury in that extremity, and that's bad, right? Swelling is our body's natural kind of like trying to make a cast. If you've got a broken injury, it's going to start to swell up around that area because it's trying to keep it nice and stable and rigid. It's doing its best, but it can't all the time. And swelling over a long period of time is bad, but essentially it's one of our body's systems to try to reduce the ability for that extremity to move. Very indicative of an injury. Okay. Gross stuff. Penetrating trauma. Any injury, anything that enters the body, and we kind of classify it by the velocity of how fast something is moving. So low velocity would be things like stabbings, where the fastest that object can go is essentially how fast can a person do this, right? There's not likely to be a lot of, force damage, where if we're talking about a gunshot wound or something like that, the bullet is going to push its way through the body, and damage a lot of structures in its path, whereas a knife is really just it's going to damage wherever it goes, however deep it can get. Now, we classify like medium as what I would say just like bigger objects impaling somebody. So I think like you can see the tree here, right, going through this person's leg. It had to be moving fast enough to impale through. That's probably like them on a motorcycle driving quickly through like a tree area and getting their leg caught, right, on a branch sticking out. That would be something along those lines. This can happen a lot in motor vehicle crashes, right? If you're like Final Destination fans or whatever, like rebar trucks. I always just have that flash of like driving behind a truck carrying logs or like rebar, and I'm like, oh boy, this is it, right? And it can go through people pretty easily. And then, of course, we got to talk about the high velocity. So bullets or shrapnel from explosions, those are going to be pieces of metal or whatever that just are forced at really high speeds through somebody. And that's where we also start to see things like this, like an entrance wound that looks like that, a small little hole, versus an exit wound or something that's more of a blast out of somebody, where that energy was first, put into a little spot, and now it's leaving somebody very quickly. Now, there's some things we got to really consider when it comes to penetrating trauma. The first thing is, if the object is still impaled in our patient, we are not going to remove it unless it is actively blocking their airway. If something is embedded in someone's trachea or in their mouth or their nose, right, if something is obstructing their ability to breathe, that's the only time we're actually going to remove an impaled object. Any other time, we actually want to do the exact opposite. We want to make sure that object stays impaled into that person and doesn't move. This image right here, hard to look at, pretty insane, but this is one of those things where it's like, this isn't obstructing his airway. The whatever this is, piece of bamboo, is just going through the skin on the side of his throat. So we would transport him like this as best as possible. We would immobilize that so it doesn't move around, but we're not going to take it out, because anything that's actually impaled into somebody is providing direct pressure on an injury. If somebody has a knife through their arm, the knife itself is putting pressure against the veins and vessels that it damaged. It's probably going to be bleeding a little bit around it. We can control that bleeding as best we can, but the minute we take that object out, we are unblocking all of those damaged vessels, and they're going to start to bleed really badly. And then we'd have to do bleeding control and put pressure and put the tourniquet on. So one of the best things we can do is just leave that object in there. Some of the more like lengthy calls and weird calls, or times where people have been impaled, like through their vehicle, through a rebar. Because what we have to do is we can't just take that rebar out. We have to coordinate with the fire department to cut the rebar to a size that we can then take that person and transport them. Some of these patients need to be transported like on the seats of their car. Like we have to disassemble the car around them, cut those rebar, take them out still on their seat, and find a way to transport them, because we can't remove those objects because they will likely die from that. So it's really an interesting kind of counterintuitive thing, but you always see it in movies too. Another thing that media does is as soon as somebody gets a knife impaled, the first thing somebody does to treat them is rip it out, and then you see all the blood start coming out. We don't want that. We just want to leave that object in, we're going to secure it. We're going to stop. We're going to apply pressure around it. We're going to immobilize that object and then bring them to the hospital so that the surgeons can take out the object. The reason why we immobilize it too is because a millimeter change in that object's location could mean the end of our patient. I mean, look at this knife. That is directly over somebody's heart. It looks like it's coming down at an angle. So while the base of that knife is very close to where the heart is, the blade is probably going a little bit past it, right? If we were to jostle that knife, there's a chance it could, move up and then nick the heart or nick another vessel or another important internal organ. So we just want to, if that patient is still alive while they got that object impaled in them, we just want to keep them as immobile as possible, keep that object as immobile as possible, so that when we move them, it's not going to be an issue. Specifically like this, right? This is another one of those times, that's the whole blade right there. But this probably just barely missed this guy's heart. And if that wasn't immobilized on the way, that blade could slip, that blade could move, it could end up, damaging something else. So if we see this, as crazy as it is, we're going to leave it in there, and we are going to make sure it doesn't move. We want to immobilize it, wrap it up, and then be as careful as possible. That's where we're going to have to be creative. We're going to have to coordinate with the fire department, whoever we need to coordinate with, to immobilize that object, get it to the correct size to transport without removing it, and get them to the hospital. Staying in similar vein here, and part of it is blast injuries. So that barrow and blast trauma. Now, there are a couple different areas in which we see different types of injuries from explosions, and we separate it into primary, secondary, and tertiary. So that primary injury we might see is from the blast wave. It's going to be that change in pressure, rapid change in pressure, damage to air and fluid-filled organs, so bladder, lungs, heart, spleen, things like that can be severely damaged. There's also a significant mortality rate for people who are right next to an explosion because of this blast, right? It can also damage the brain and the skull and all that kind of stuff. So where somebody is in proximity to the explosion has a big part to play. So primary is somebody who's very close to the actual explosion. Now the secondary injuries is going to be shrapnel injuries. So objects that are sent flying at high speeds due to that rapid change in pressure. If you guys remember the Boston bombing at the marathon, what those guys did is they made homemade explosives, and they loaded it with things like ball bearings and other broken pieces of metal so that when it exploded, it would send as much shrapnel out as possible, killing and damaging as many people as possible. So essentially, if you have an explosion with a bunch of things around it, they become little bullets as they fly out in that radius from the explosion, and they can damage, they can essentially impale people and go through like bullets would. So shrapnel injuries can cause a lot of bleeding. They can cause significant damage inside the body, and especially because there's a lot of chemicals involved, and typically if an explosion is going off, the things inside or the things that become shrapnel are not really sanitary. There's another high risk of infection. If you're around trees or anything like that, and a tree becomes shrapnel, those wood shards, whatever it is, they also break up into really tiny pieces. Like somebody can have dozens of tiny pieces of shrapnel, kind of like a shotgun blast or whatever, inside their body, causing infections. So then after secondary, we've got what we call tertiary injuries. And this is mostly going to be blunt trauma. Depends on what they're thrown into. But this is essentially somebody who is a little bit further away from the initial blast, but still had some of the energy exerted on them. So the explosion happens and they are thrown backwards by that explosion into something causing injury, or the explosion has damaged the area around them and then it causes an damage to them. So an explosion inside a building, if someone is thrown against the wall, or the explosion causes part of the building to collapse, those would be like tertiary injuries in a blast trauma situation. Usually they're propelled into an object, but if they're depending on whatever they're thrown into, it could be impalement as well. Okay. So when we talk about injuries and when we talk about soft tissue injuries, so things to our skin and our muscles, what we classify things as are three different things. Really, there are closed injuries, open injuries, and then burns. So when we're doing our trauma assessments and you get down to the legs or the arms and I say, oh, patient moans in pain, you expose it, what do I see? And I see you see a closed but angulated fracture, right? I'm basically saying you see a deformity, you see an injury, but the skin is still intact. It's not an open wound. They're not actively bleeding. It's a secondary injury. Now, an open injury would just be anything that has caused the skin to break, a break in the surface of the skin. This can be an outside force causing a laceration, causing a cut, but could also be somebody breaking a bone, and that bone exits their skin really quickly and penetrates through. Most of the time, like when we see compound fractures, compound doesn't mean that the bone is actively sticking out. It just means that the bone went out and damaged the skin. A lot of times it just goes quickly out and goes back in. You might see like the bone, but it won't be like sticking out at an odd angle like they do in the movies. You also might just see like an open wound that you're not sure what happened. Somebody was just like, yeah, I fell really hard and I landed on my arm and now I've got this big gash and it hurts a lot. And what you might recognize is that they broke their arm and the bone came through the skin. One of the main times that I remember seeing this is a woman was getting out of a tall truck in the wintertime, and there was a patch of ice underneath her foot. So essentially, she rolled her ankle like that. Like she slipped and came out of the car. And when we got there, she's like, I heard a snap, but I'm bleeding. It's so weird. And I looked at her ankle. There was a big open wound right about where that ankle bone would be, but I don't see the bone. And I was like, ooh, boy, when you stepped out, it seems like you essentially went to the side and your bone came through your skin before you righted yourself. So in open injuries, we're going to have to be controlling bleeding, reducing risk of infection, so actually covering those injuries, covering those wounds. But just recognize you might not see classical like bones sticking straight out. And then burns, this is just, it could be thermal, chemical, electrical. Again, we're going to talk more about burns in our environmental lecture. But there's a lot of different ways that somebody could be burned. It is type of a soft tissue injury, can be involved in trauma, but we don't have the same treatment as we would for any other traumatic injuries. We can't really stop bleeding because burns are just going to do that themselves, really. We have other things that we're going to prioritize. Okay. We're going to go deeper into the injuries here, but it's getting close enough to 6:45, and that's a big change in topic, so we'll just take our break now, if that's okay with you guys. Come back at, fine, I'll give you 16 minutes. We'll come back at 7 just to make it nice and round. How's that sound? Cool? All right. See you in a little bit. So we were just going to go over the specific injuries in a little bit more detail. Give you some more visual examples. So again, a contusion, that is a result of blunt force trauma. It is a bruise in a sense, but it's more on that there is just direct damage to the capillaries and veins and the tissues underneath, likely to see pretty much immediate kind of discoloration and that bruising. Pretty common. Not necessarily indicative of like a life-threatening injury, but definitely could be telling for, like a fracture or something along those lines. This is a pretty extreme hematoma, but this is the difference. A lot of times, like bruising, contusions, and hematomas are mixed up, whereas a hematoma is going to have that kind of distended look to it. It's going to be a pool of blood that's collected. So oftentimes also a result of like blunt force trauma, but it's just going to be more of that swollen, darker kind of color. Usually we like the egg on somebody's head, right? That could be described as like a hematoma. Somebody takes a knock and then we see that welt kind of form up. That would be blood pooling underneath the skin, and it's going to be protruding a little bit. Abrasions, again, these are caused by friction. So if you remember being a kid and running around on your hands and knees on the carpet and you get those rug burns, that's essentially an abrasion where the skin is rubbed off by friction. It's going to happen really anytime somebody falls. We see it a lot like on pavement and stuff. Also very common when people are riding bicycles or motorcycles. That's why people who have motorcycles should be wearing like leather and protective clothing anytime they get on, no matter the weather, because they can kind of turn into like a human crayon. If that vehicle goes off, they fall off their vehicle and they slide along the pavement. They're going to have a lot of really bad abrasions. That road burn is kind of what else it's known as. Now, avulsions, or lacerations, sorry, I messed up my order. Lacerations, these are just smooth or jagged cuts through the skin and potentially down to muscle. It could get as deep as the bone, but anything that slices through the tissues, the skin, the muscles. This was likely caused by a boat propeller, right? Somebody swimming with their legs and trying to get away from a boat or trying to get on or whatever, and that leg gets caught, cut a bunch by those rotors. Could be knives. It could really be anything sharp that slices through the skin. Oftentimes, bleeding is very present in these injuries, and really the depth of it is going to be a big part in what causes bleeding or not. It's kind of interesting here. I mean, you can see the different layers of skin like we've been talking about. You can see the epidermis down through up until that's muscle tissue right there. So like just underneath the subcutaneous tissue. But you can kind of see how our skin is made up in these situations. Gross and interesting at the same time. Now, avulsions. This is the separation of the various layers of skin. So typically the skin is still attached to the body, but there's going to be a flap to it. This is actually a picture from one of my calls. The patient told me she was in very good spirits when this happened. She told me that I could use it in educational purposes if I want it. This was taken to send ahead to us by first response units. I'll give anybody, like, I'd give you money if you could tell me what caused that avulsion, because I was completely floored when I learned. Give me a guess if you want.
Did she like drop something? Like, I don't know, like I don't want to say a knife or something. I don't know. Did she like? I feel like something like fell on her. It looked like, I don't know.
Something didn't fall on her. She fell on something. So not a dishwasher door either, Michelle. I like where you're thinking though. That's a unique answer.
Did she fall into like a cup?
No, but that's a good thing. She fell on something that was helping her walk. You know those aluminum canes that have like the little buttons to slide and make it shorter or longer? She was walking with the cane, got it caught, and then kind of pushed it backwards and rubbed it against her leg. And the little, the area where those two different pieces of aluminum come together is just a tiny bit sharp. But it was sharp enough where the weight of her falling and the pressure of her arm just like sliced through the skin. And it's kind of hard to see in this picture, but it was a big flap. Like it was her leg and then it was hanging off the side. Again, she was in good spirits. It's not a life-threatening injury, probably pretty painful. Not a large amount of bleeding here. You can see some on the pads that we had, but we really just we made sure there wasn't any debris in there. We ran some sterile water over it and then wrapped it up and brought her to the hospital. So again, not a whole bunch of life-threatening things here, but I mean, if we saw the picture of the guy earlier where it was his scalp and his head, different issue. But this one's always interesting because, it just wouldn't expect someone to be hurt this badly from the thing that helps them walk, their cane. But it was all just based off of that little tiny ring of unpolished aluminum.
For those cases, do you put the flap back where it belongs, or do you just wrap it up?
I'm not really going to try to put the flap back. Honestly, I kind of want it a little bit more open so that I can see if there's anything in there and I can clean it out. And then I'm just going to bandage it up. I don't want to spend a lot of time doing anything like that. Really just kind of leave it how it is, make sure it's as clean as possible, and then just bandage it as you would. At the hospital, I don't really think that they would try to put that back. They might just have to, heal and grow their own, a new layer of skin. Okay, So the important thing when we're talking about treatment and care of these soft tissue injuries is where they are and the bleeding. If there are injuries around the mouth and the airway, that can cause obstruction of the airway. If somebody is actively bleeding into their airway and they have to constantly be removing blood from their airway, that would be an obstruction. Or if we're talking about a soft tissue injury like in the airway itself, to the tongue, to the cheeks, to the soft palate, anything like that could be a big issue. So keep in mind you might need to be suctioning out some blood. You might want to have them on their side depending on the, their spinal injuries, if any, just to have some of that blood drain out. And it's it's challenging to stop bleeding in these situations because we can't really like put pressure over somebody's airway. If it's on the side here, like this image, probably not too hard to do, but it's one of those things we have to keep in mind. Also, injuries to the face and the airway are a contraindication for us to then use an oral or nasal airway. Really, that's kind of the only contraindications besides somebody not being able to tolerate them, is that if there's an injury or something in that area, we don't want to be inserting something in that space. We don't know if we could be making it worse with an oral airway, or if they have other injuries inside their sinuses or whatever, or if the injury has caused structural changes. So we can't just go put anything in there. So just keep that in mind. It could lead to challenging treatments. If for some reason we needed to bag them or anything like that, around an injury, it could be pretty challenging. So we're always just going to start with assessing the ABCs and care for life-threatening injuries that we see. Anytime there is blood on the scene, we definitely want to be following good BSI precautions. Anytime there's a lot of blood, gloves and goggles, definitely. It's just things can splash. If somebody has an actively bleeding wound, we don't want any of that stuff in our eyes, ears, nose, or mouth. So don't be afraid to put on a pair of protective glasses and extra BSI if you need to. The other thing about bleeding is if somebody's swallowing a bunch of blood intentionally, or not intentionally, not vampire or whatever, maybe intentionally, you never know. Some people do that kind of stuff. But if somebody is, ingesting enough blood, it oftentimes will cause or lead to vomiting. So just keep that in mind. If somebody's got an airway injury and they've been spitting out blood a lot, it could also lead to them vomiting, which in itself is another airway issue. And then appropriate precautions for neck injuries. This really means call ALS and just be prepared. Treating bleeding from somebody like having a throat injury is really challenging for a couple different reasons, right? If they have like the carotid artery or a jugular vein, right? If we're putting a whole lot of pressure across their throat or whatever, we could also be cutting off their airway and the blood flow to their brain. If they have an injury to their airway, we can't put a lot of direct pressure on that because we're going to end up choking them. And it's also now become kind of like an unintentional stoma, right? They have a new airway that if they try to breathe in, the air is going to be going in that instead of their mouth, and it's going to be hard for them to do so. So in these situations, if somebody had something impaled into the airway, there's a new path into their trachea. That's one of those times where we could use like an occlusive dressing, which we're going to talk about in a little bit. Try to create a new layer of skin over that airway so that they can continue to breathe. Whereas if they have like a carotid or a jugular vein injury, we just want to try to put as much pressure on one side if that's possible. Unless they have it on both sides, that's going to be really tricky. But you can put direct pressure on the side of someone's neck, but not in the direct center, right? We can't cut off their airway, but we can try to stop the bleeding from their jugular or their carotid. Those are just bad situations. Those are some very big veins and arteries that we have in one of the more vulnerable spots of our body. Gunshot wounds. So they have unique characteristics. They're really high velocity penetrating injuries. Bullets go really fast. They are directly designed to kill people or kill things as quickly as possible. The thing about bullets too is the number one cause of preventable death after injury is bleeding or lack of bleeding control. The main reason why, we're in America, guys, we have to talk about it. The main reason why people die in mass shootings is because of bleeding and blood loss. Bullets, again, they don't work like they do in the movies. Unless you're hit in some very specific spots, like your brain, your heart, parts of your spinal cord, you're not going to just drop immediately and die like people do in the movies. There's not going to be like that cinematic puff of red smoke and somebody does wah and falls down just immediately dead. Bullets are really fast knives and they cut. And so majority of the people who die in these situations were shot in an arm or leg or in an area where the artery was hit. They weren't able to have bleeding control done. They either didn't know how to do it to themselves or people around them didn't know how. And that's the reason why people die in these situations. So the other challenging part with gunshot wounds is they could be a through and through. There could be two injuries that are bleeding that we have to keep in mind. There could be an entry and an exit wound, essentially usually on the other side of where the path of the bullet went. Or we might just see one small entry wound and the bullet essentially has not exited them, but probably caused some severe internal damage. Now, one of the things about exit wounds is the way that bullets work is the entry wound where they penetrate somebody is going to typically be smaller than the exit wound. Depending on what type of bullet was used, some are designed specifically to create a bigger exit wound. They break apart in the body. The bullet spreads as it goes through. It hits the person's body. That force on the bullet causes it to expand and pop out the back, push out more stuff. Whereas if it's just like a really fast bullet and a really strong bullet or like meant to pierce, it'll go through and through and it won't cause as big of an explosion out the back, but it can still cause these two injuries. So we kind of have this little bit of a diagram here showing 22 caliber bullets are very small, so even the exit wound will probably be small. A 308 is relatively small, but it also moves very fast, so it's going to go through. And then when we get up to like the big calibers here, like 45, right? Those are big pieces of lead essentially, and when they hit somebody's body, they tend to burst out the back. So you can see here, looks like there was a smaller entry wound right here versus this giant exit wound on the back of his hand. I don't know exactly the story behind these images, but I would hanker a guess that it was a mistake. You can see the burn right around the bullet wound, so that meant the gun is pressed against the wrist. So I feel like this might have been in a cleaning situation or just an accident. This isn't really like a spot that somebody would press a gun against to and pull the trigger for a good reason. But you can see that in that area, it kind of went through this angle out the back, and it was a bigger bullet, and it caused a large exit wound. So things to keep in mind, right? Especially if somebody's been shot with like a 22 caliber, it might be hard to initially assess for where that bullet wound is. It can be a small entry and a small exit, but it could still be a lot of bleeding, and it could be a lot of internal damage. Just a story here. This is from Chris McCarthy. You met her last week, my EMT instructor. She went on a call where it was for abdominal pain, right? And this is also about scene safety. The call was for abdominal pain. They show up. There's a woman sitting in the middle of the living room surrounded by her family, including her husband. She's holding her stomach really tightly, and she's like screaming in pain. Chris goes over, starts assessing, be like, hey, what happened? What happened? Are you vomiting? Like, what's going on? What do you feel? And the woman goes, he fucking shot me, and points at the husband, who then runs out of the room, right? So what did Chris and her crew do? Yeah, they got the heck out of there, right? They took the patient with them. They got into the ambulance and they drove away. They called the police and said, uh-oh, right? Anytime somebody has been shot on scene and the person who shot them is there, it's just never a good thing, especially if they rush out of the room. You never know what they're going to do, either run away or go and grab their gun. So one of those situations, they got a call for abdominal pain. They found somebody holding their abdomen, which could be like they've got the poops or they got shot. Really, we don't know. And they didn't know it was an unsafe scene until they learned that information. And when they did some assessment, they did have a very small bullet hole in their abdomen where they were shot, right? So just a couple different things there. Hard to assess sometimes, and then can be dangerous for us. This also kind of goes back when we talk about cardiac arrest with like penetrating injuries and blunt trauma, right? You remember that we have an extra set of steps that we have to think about before we actually do cardiac arrest. cardiac arrest work on somebody who's had a blunt or penetrating injury. And one of the things with bullet wounds that makes them so challenging is the actual act of bleeding control and the fact of internal damage, right? If somebody's been shot through the heart with a bullet, even if we do really good compressions, there's no way that we're actually going to be able to return a normal heart rhythm to a completely damaged organ, right? The other thing is, if they have a lot of bullet wounds and we're doing compressions, if we haven't actively been able to control the bleeding in all of those separate holes, when we do compressions, we're just pushing blood out of all those bullet wounds. All right, it's pretty unfortunate. It's like hard to see where you're compressing on somebody's chest and you see little like fountains of blood come out of the holes that they have in them, and it's really hard to find and control all of them, especially if they've been shot by quite a few bullets. So keep that in mind. Bleeding control always is going to come before cardiac arrest work, if anything. But remember, in our protocols, if somebody was put into cardiac arrest by blunt or penetrating trauma really before we get there, we're not going to do CPR because the chances are it's not going to work. Okay, some of the more gross stuff here. Crush injuries, really messed up. This could be anything that essentially is too heavy landing on and pinning somebody down. We do live in a state where there's a lot of farming, a lot of heavy equipment that could fall or crush somebody. We also live in a state where there are a lot of highways and things like that. There's a couple extra things we have to think about when we talk about crush injuries. As you can just see from these images, they are just very catastrophic, destructive. Like the injuries just look awful. There's a lot of bleeding that's going to happen because every vein, vessel, and artery in that area is going to be damaged. The bones are probably damaged or crushed or reduced, right? All of that stuff is going to be very painful, hard to treat, hard to immobilize. And then the other thing that makes these challenging is something called compression syndrome or rhabdomyolysis. So this is in a situation where, let's say, somebody had a large boulder fall onto their arm and they've been pinned there for a while. I'm not relating this to a story. It's just that movie or whatever. But this probably would have happened to him and why he ended up cutting his arm off in that story. When the blood flow is cut off to areas of our body, our tissues, after a while, start to decompose. They start to degrade, right? If there's no circulation, the tissues are starting to die, and essentially they are secreting and putting out these really toxic chemicals, essentially death chemicals, into that area because there's no blood flow. If for some reason the blood flow is then restored to that area and those chemicals start getting pushed back into the body, that can cause a lot of other conditions, specifically rhabdomyolysis, that compression syndrome, because all of that degraded, that decomposing stuff is then kicked back into the body and can cause like organ failure and death and all sorts of other stuff. So this is something to think about. A lot of times when people have crush injuries, they're not immediately freed because it does take quite a bit of effort to get whatever that object is off of them. So we have to be considerate of that. If somebody's been pinned under something for an hour or more, really, any length of time, I would say over a half an hour, I'm going to be calling medical control and seeing what they want me to do, worried about compression syndrome. But essentially, the best thing we can do is apply a tourniquet high and tight above that and apply it, right? Cut off blood flow so that if we remove that object, the gross stuff can't make its way back into the body. It's just going to get stopped by that tourniquet. So we can apply a tourniquet before somebody has the object removed from them. Good news is that the object is most likely providing pressure and stopping bleeding. Like, they're probably not bleeding while the object is crushing them. But as soon as we remove that object, they're going to start bleeding and it's going to circulate back in. So we can preemptively apply a tourniquet so that this doesn't happen. But really, that's basically what we're able to do. Any of these kind of extraneous circumstances, I am definitely going to be on the phone with medical control, wondering what they want me to do, because we have protocols for these. What we can do is tourniquet, but it's always a good idea to have a doctor in your ear to help you walk us through this type of situation. These are really bad situations. People tend to not really be able to regain a lot of the function in that arm or that extremity or wherever because it's just been so heavily damaged. And then also, depending on how long they were there, it being degraded for so long can probably lead to some amputations. All right. Abdominal eviscerations. This is essentially anytime we can see somebody's intestines, their internal organs. It's really anytime an organ is protruding through the abdomen. This can be caused by penetrating objects or lacerations. We don't have too much skin and stuff between our outside of our body and our internal abdominal organs. We do have a good set of those abdominal muscles, some of you more than I, but it's just one of those things. If there's a deep enough cut or an injury, these will come spilling out. We do have, it's like a pressurized system in here, so if there's a quick opening, things will protrude. I mean, good news. Good news is there's probably not going to be a whole bunch of bleeding unless an artery was also damaged. Most of the stuff in here is kind of free floating. That's one of the things that I found really interesting when I was learning about medicine and stuff. But when you do like an abdominal surgery and you are trying to fix an injury like this, there is no direct order in which the intestines go back in. There's no like specific place that they sit in. Doctors will just put them back in the abdomen, close it up, and then your intestines kind of sort themselves out. If you didn't know this, your intestines move on their own. They just kind of shift around. If you've got like a cramp in your abdomen after eating some bad food, that's what you're feeling. Your intestines are constricting and trying to push whatever it is out. So it's just really interesting. When you push it back in, it figures itself out. But there is an extra kind of treatment step that we do for these patients. And we want to keep these areas covered with a moist, sterile dressing. Your internal organs are used to being moist. They should not be getting dry. If they're exposed to the air directly, they're going to dry up. So we have like a big trauma dressing that we would then soak essentially or pour sterile water on. In the back of your ambulance, you should always be carrying, or your department should always be stocking bottles of sterile water for situations like this, where we can take the dressing, soak it, and then wrap that around those internal organs so that they stay nice and moist rather than getting dry. You could also use like on top of the dressing some like plastic wrap would also be good. I hate to admit this, but there is a scene in Grey's Anatomy where a doctor does this, and it's pretty good. Don't tell anyone I said that. Okay, essentially, cover it with a moist, sterile dressing. That's also going to help with the bleeding, doing some direct pressure, but we really just want to preserve these organs, so keep them nice and moist with those dressings. All right, amputations. Woof. If somebody has a partial amputation like you see here, we're going to essentially immobilize it as best we can. We have bulky dressings, and we're going to splint them. So really, really try to immobilize them. Keep them where they are so they don't get any worse. Use padding. Use a lot of really thick pads of gauze, and also splints and stuff. This is probably a time that I would use like a SAM splint. The vacuum splints might just be a little bit much around something like this. Now here's one of the uncomfortable parts. If there's a complete amputation, an extremity is removed from the body completely, we got to pick it up and we got to bring it with us. We have to put it in a biohazard bag, try to store it in like a cool place. If you've got ice packs, crack as many ice packs as you can, put them in there with that amputated extremity, and bring it with you. There is a chance they can reconnect them. It also helps them with assessment, seeing like how much their body was damaged, if there's a part missing or whatever. But yeah, it's kind of uncomfortable. I had a friend who went to a factory accident where somebody had a very clean arm amputation. Their arm got caught in one of the machines and it essentially sliced it right off. And we were like basically right out of the EMT class, and he just recounted to me how they walked in. The paramedic, luckily the people on scene had already stopped the bleeding. So the paramedic went over and they looked over and said, "Hey, Sean, go grab the arm." And you had to go pick it up and put it in a bag and then bring it with him to the hospital. So never had to do that myself, but it's one of those things. It's uncomfortable. It's kind of gross, but it could be reattached. It's also really good for the information at the hospital. So we want to bring it with us. Keep it on ice. Don't touch it more than you have to. Okay, we're out of some of the more gross things here. Now, again, we're going to talk about burns more in depth when we get to like our environmental emergencies, but to give you a rundown here. It's interesting. When we talk about burns, we have to directly understand the layers of the skin. So I mentioned that earlier when we were talking about those lacerations. But burns directly line up with, or the severity of burns directly lines up with the degree that they have affected our skin. So a first degree burn, or what we would call, oh my gosh, no, I can't, superficial. Sorry, I don't know why I forgot that word. First degree or a superficial burn is only affecting the epidermis, the outside. So that's going to be anything like a sunburn, right? Or I touched the hot stove earlier when I was cooking dinner by accident. I have just a little tiny red spot on my finger. That's a superficial first degree burn because only affected my epidermis. Pretty painful too. I mean, if you've ever had like a really bad sunburn, you know that like it's just going to be a rough couple of weeks while you get healed. It's going to be itchy. You're going to feel hot. You're going to feel cold. It's going to be uncomfortable. But in the long run, really not life threatening. If somebody has a really bad first degree burn, get some aloe. You know, stay out of the sun. Wear sunscreen. Drink a lot of water. But it's probably not going to be life threatening. Anything past a second degree burn can be life threatening. Less so as second degrees, but second degree burns get down into that second layer, the dermis. And this is where we start to see like what we call blebs, really bad blisters, just showing us that lower area of the body, lower area of the skin has been damaged. And it's going, essentially, if we get anywhere past the epidermis, we're getting down into the area of the body that isn't designed to protect like against infections. So the epidermis is how we protect against things getting into our body. So if a second degree burn happens, we're getting down past that epidermis layer and they are at higher risk of infections and things like that afterwards. So really, if you're seeing the presence of these big blebs, these blisters, and I'll show you a picture in a minute, that's indicative of a second degree burn and it moves up in severity past that first degree. Also, second degree burns are very painful. I put a little bit of a star after the mega painful when it comes to third degree because a lot of people are like, oh, well, second is less than third, so third has to be more painful. But not necessarily. Because third degree burns, they go down past the dermis into the subcutaneous tissue, potentially to the muscles, and oftentimes they burn the nerve endings. So there is no actual pain being absorbed in the area of that third degree, like charred burn. And people who are having third degree burns are in so much pain because they have quite a few second degree burns as well. So there's some argument that second degree burns are some of the more painful burns. So then that third degree gets down past the subcutaneous tissue, potentially to muscle, potentially to bone. And these are really kind of indicative when we see charred or like blackened or burned skin. And they're going to be surrounded most of the time and kind of like a target bullseye out, like a dartboard kind of deal, where the highest area of heat or energy, where the third degree burn happens, it starts to get less and less as it goes around. So we'll see a third degree burn surrounded by second degree burns, surrounded by first degree. And it's all of those kind of burns in tandem, creating a lot of pain. So right next to me, we have a pretty severe first degree burn. You can even see just like a little bit of a blister forming. That's not a bleb. What you see on that guy's shoulders over there, those like pussy yellow burns, those are what we consider to be blebs. That's evidence that it's going through the dermis or into the dermis. Whereas this person needs some aloe. They were out in the sun for too long. They should definitely hydrate very well and apply sunscreen if they ever have to go outside again. You see the blebs over there on the shoulder injury, those shiny kind of yellow looking blisters. And then down here, we've got the third degree burns where you can see the charred skin where it got down past those first two layers. But then you can also see the differentiation between like a second degree burn right here, right, and then a first degree as wherever the heat was kind of dissipated, right? Now, I'll be honest, I know how bad second degree burns feel because that is me. With second degree burns on my shoulders. This was the result of a weekend on a lake. I applied sunscreen pretty diligently, or so I thought, but when I woke up on Sunday morning, I had a lot of stiffness in my shoulders and I felt like I couldn't move them. And I went in and I checked and I realized that I had pretty severe second-degree burns all across my back. Like, this is just one shoulder. I had just this many blebs and burns all across the back of my shoulders on both sides. And I'll tell you, this was incredibly painful. You can also see I have really bad first-degree burns around them as well. I went on rescue duty 2 days later or so. I was on shift, and I had taped like burn dressings over them to give me some relief and to stop them from leaking through my uniform. And the worst amount of pain I've ever been in was when I changed those dressings, and when I pulled at the tape, I ended up essentially taking all of the skin off of both of my shoulders in just like a slop. Very painful. Also, the danger of infection is higher because these, if they're popped, if they're damaged, those are just direct holes down into a layer underneath the epidermis. So a lot of times, if people have really severe burns across their body, if they're damaged, if they got dirt or whatever in them, they're more susceptible to infections after the fact. So just keep in mind, wear your sunscreen. Very painful. Now, when it comes to assessing people with burns, we not only want to assess what caused the burn, electricity, chemical, or heat, where the burn's affected in their severity, so first, second, or third degree. I forgot to mention, the titles first, second, and third degree are starting to move away. We're using superficial for first degree, partial thickness for second degree, and then full thickness for third. That's just one of those things as well. I've been meaning to put that in my presentation. I forgot to do that this time. It's still going to make sense to people if you say first, second, or third degree burn. But in EMS and medicine, we're starting to try to differentiate it a little bit more because it's not as simple all the time. So superficial, partial thickness, and full thickness on the way up. The other thing with assessing people who have been burned is we want to give a rough estimate to the hospital of the percentage of their body surface area that has been affected by the burns. This is definitely going to play into how they're treated at the hospital or how severe their injury is. And to make it a little bit easier on ourselves, we have this rule of nines. I say that as if it's easy to remember, but essentially we can use this chart to give a rough estimate of how much surface area of somebody's body was burned. So the idea here is that a whole arm, front and back, is roughly 9% of the surface area. So if the whole front side was really burned, that would just be 4.5% of their body. Whereas if it was a whole arm burned, that would be 9%. The front of the abdomen is 9. The front of the chest is 9. The front of each leg and the back of each leg is 9. It's just one of those things where you can look at somebody and be like, okay, that burn roughly covers their entire chest just on the front. It's about 9% of their body burned. The head itself, front and back, is 9. And it's just one of those things we try to estimate. It doesn't have to be like 100%. You don't have to calculate it down to the exact, percentage of their body, but the hospital does want an estimate. This can be tricky though, if it's not like all one arm, maybe they're different patches of burns. So another tool that we can use is called the palm rule, where if you take the patient's palm without their fingers, roughly that size, that's about 1% of their body. So for me, it has to be their palm, not yours. So for me, let's say if I got burned like here, that would be probably 1 to 3%, right? You can use their palm to estimate smaller burns. So if it's spread across their body, it's not as easy to use the rule of nines. You can use the palm rule. Just remember, it's their palm, the patient's palm, not yours. There's also a pediatric version of this, which we'll talk about when we talk about burns. So treatment. First degree, like I said, minimal treatment is necessary. Oftentimes hydration and get them some aloe or some soothing ointment. That's probably going to be the best deal for them. If they've got like 100% or 90% of their body covered in first degree burns, I'm still going to bring them to the hospital. If they want to go to the hospital, we should still bring them. They might have some help there. But really, sunscreen, stay out of the sun, drink a lot of water, apply aloe. Second degree burns, though, is when we need to really start stepping in. So do not pop those blisters. Those blisters, while painful, are also still a layer of skin, preventing things from getting down into the body, reducing some infections. And we do have specific sterile burn dressings that we want to use. When it comes to burns, we absolutely want to prioritize sterility. So we can cool them down. We can wash any dirt or anything off of burns with that sterile water and then cover it with a sterile burn dressing. Same thing with third degrees. Now, I was mentioning earlier that, burn patients typically don't die from the burns themselves, but other things outside of that. Why is it so important that we keep burn patients warm? What part of their body is being affected to make that necessary, and why? They have less skin to keep the heat in. It's not that the skin acts as an insulator. It's something else. So you're on the right track there, Jackson, but it's not like we produce heat only in our core and then our skin keeps it in. Our skin also produces heat. It's another factor. When we talked about skin, like the integumentary system in our like A and P, I mentioned one thing very important. What does skin regulate? It regulates.
Is it the sweat gland?
And so it does regulate
the vessels?
Yeah, it regulates the sweat gland, or the sweat glands are in there. The skin regulates our body temperature. It is the connection to the environment where it tells our internal systems to sweat more, to cool down. It gives us ability to know how hot we are. If the skin is gone, there is no connection for sensation like that. There's no connection on determining what the environment is like. So, if somebody is severely burned, they've lost the top layer or at least the second layer of their skin. Oftentimes, people who are really severely burned will die of hypothermia in summer because their body is not able to regulate the temperature. They're not able to know that they need to keep themselves warm, and so they just don't produce any heat, and they can't keep themselves warm, or vice versa. They can also get hyperthermic really quickly too if they're in too hot of a situation. So we really need to prevent any gross things like dirt and stuff getting into exposed burns, but we also want to keep them nice and warm, but not like too warm. Like, we're not going to keep them boiling, but we're going to treat them for shock, keep them warm, heat on in the back of the ambulance, nice tucked up with blankets, with those sterile burn dressings on. It's just one of those things. It's really interesting. Once they lose that top layer of skin, their body stops being able to be connected to the temperature of the environment, and the rest of their systems just don't work. Okay, musculoskeletal injuries. So fractures. That would be a bone that is broken. Now, there are different levels of fractures. It could be very thin. It could be hairline. We might not be able to see a deformity. We might be able to see evidence of a fracture, though. So things like swelling and discoloration like this, you might not see just like a straight up broken arm. You might just see like swelling, guarding, and that they're really in a lot of pain, but it could also just be like a hairline fracture. It could also be just like straight up broken. The arm falls, about midway through and is dangling down. It could be something more dramatic like that. Now, so a dislocation is when a ball joint, or essentially just any joint, is disrupted. Typically, the most common things we see are like shoulder dislocations. Some people's bodies and like their ligaments, previous injuries and stuff too, can make people more prone to dislocations. I played rugby in high school, and I was a second row, so my job was in the scrums, like reaching over a lot and like being on the ground. And I was like, I got my shoulder dislocated a couple times from just like it slipping down, and then having to get it popped back in is never fun. So dislocations, less so a break of a bone, more so like like it moves out of its socket. It can rip and tear ligaments and stuff. It could also cause circulation to get cut off. So it's still pretty severe, but it's usually not like a snap or a fracture. Now, this is another one of those things in medicine, sprain and strain, where they just decided to use two very similar words and they thought it was easy to remember, but at least for me, it's not. So a sprain is when a joint injury, or there's an injury to the joint with tearing of ligaments. So the things that keep our bones connected to each other, whereas a strain is the stretching or tearing of a muscle. So at like the elbow, we have a bunch of ligaments in there. If that is sprained, it would be the ligaments that are damaged, where if I strained it, it would be the muscle that is torn or damaged. So that's why we usually say like ankle sprain, right? You don't really strain your ankle, you sprain it, whereas you can strain your calf or like your hamstring. So with fractures, essentially what we're able to discern is it open or is it closed? Like I was talking about earlier, a closed fracture is one that doesn't break the skin. There might be deformity, there might be very clear fracture, but we can't really do any bleeding control or anything like that. It's also probably not too much of a life threat. It's a secondary injury. We can splint it after we take care of their life-threatening injuries, whereas an open fracture does have an open wound, an external wound associated with that break. You might see the bone sticking out, you might not, but in general, if there is bleeding, we're going to have to control that before we go along and start to splint anything. So, more signs and symptoms of a fracture. One of the biggest ones, clearly, deformity. If you can see an obvious change in the symmetry or how that extremity is supposed to look, right? You can see that this wrist has been moved off to the side and the radius and the ulna are still trying to go straight, whereas this hand and the phalanges and stuff are not. Tenderness is definitely present. Somebody is going to be in a lot of pain if they have a fracture. They're also probably going to be guarding it, right? If someone's got a broken arm, they're probably going to be tucking it against themselves, protecting it, because any sort of movement, any sort of jostling of it causes quite a bit of pain. Swelling, like I was talking about, is one of the first things the body is going to do. It's going to try to swell that area as its own little bit of a cast, its own attempt to be a little bit of immobilization. Bruising with that blood kind of starting to pool in the area. Now, crepitus, this is a new word for you guys in class. This is the term for the sound of broken bones rubbing against each other. So if you ever break pasta, if you were to, next time you make pasta, right, and you're going to do the not very Italian thing and break it in half, take those two handfuls of like spaghetti, hold them tight, and then grind them against each other. That's kind of what it sounds like. It's a grinding, it's a crunching, it's a squeaking. And that's just the sound of bones rubbing against each other. It's a pretty gross sound. So if you're assessing an area, like you're palpating the arm and you hear screek, creak, creak, that means there's broken bones and they're rubbing against each other. And then, of course, if you see a visible bone sticking out through the leg, that's not a good time. So we talked about these a little bit already. Dislocations. You're going to see a deformity at the joint. So they're probably going to have loss of motor function. It's going to be like dangling. They might not be able to actually lift or control that arm. And it's probably going to be a little bit like reduced, like down a little bit longer than their other one. There's also the potential for a loss of distal pulse, like they lose that circulation because the ball joint has slipped out and is pressing against the artery going down into their arm. So it could cause a lack of circulation. Now, we are not allowed, it's not in our scope of practice, to put shoulders back in. I understand it is a relatively easy process, but it's only really done after they've confirmed that there's no other damage. So I have definitely been asked by patients who have dislocated shoulders and they've called 911. They say, well, hey, last time my buddy Greg just like grabbed my hand and pulled it really hard and snapped my shoulder back in. Why don't you just do that? And I basically say I'm not allowed to. The doctors, if they think that's necessary, will do that up at the hospital. So even if you know how to do it, don't do it on the ambulance. It is out of our scope of practice. So we're just going to essentially treat this as a joint injury, right? So when we splint, someone has a shoulder dislocation, we'll just use that sling and that swath, and we'll keep it nice and secure, reduce their amount of pain by supporting it, immobilize it, and bring them to the hospital. But when we're in treatment of any sort of fracture, these are definitely times to call ALS for pain control, right? We've been talking a lot about like pain medications, opiate use and stuff. And we've been focusing a lot on like the negative sides of it for abuse and addiction. But it is absolutely, totally 100% okay for you to be concerned with the amount of pain your patient is in. And just because fentanyl is a buzzword right now, and so is ketamine, it can really help our patients. I have definitely responded to people with severely broken bones. They're not in any life-threatening conditions, but they're in so much pain that we're not able to move them without them being in too much pain. So I would much rather stay on scene, wait for a half an hour, hold manual stabilization or whatever until a paramedic can arrive, give them some pain meds so that we can start transporting them. Any movement that this person experiences with a fracture or anything like that is going to cause quite a bit of pain. If you think about it, the stretcher that they're on, it's going to be bumpy. You're going to put them into the back of an ambulance. It's going to be bumpy. There's a lot of pain. These people could absolutely benefit from some pain control. If there's no paramedic in your range, we are now allowed to give acetaminophen and ibuprofen, right? So as it's not as great, it's not going to provide as much of an instant relief, but 15 to 30 minutes later, it might take the edge off. Okay, so a couple of these we already talked about a little bit, but these are the life-threatening injuries, the next two ones, that we can treat immediately, and that we should. So, spoiler, for your NREMT test, your trauma assessment exam, they are going to give you one or the other of these, essentially, and you're going to need to know how to treat them. First things first, sucking chest wounds. This is essentially a hole into the thorax, right, into the lung area, where we see air entering and exiting this wound, and it's typically bubbling like you see in this image. This could cause air to enter the chest, right? Every breath, they're drawing air in through that hole, and it might not exit when they exhale. So the pressure is slowly building up inside their chest, potentially causing pneumothoraxes, right? And up to that point where the pressure could cause the lung to compress and move that trachea over, that tracheal deviation. So we can apply direct pressure, but essentially we won't be able to necessarily stop the bleeding per se. So what we want to do is we just want to apply pressure, wipe away the blood, and then we have a special type of dressing called an occlusive dressing that we're going to put right on top of it. It's essentially just a really big sticker that's thick and silicone-y, and it's really sticky. So when you put it on and you seal it down, essentially you're creating this really thick new layer of skin. And if we cover that hole, it's going to stop air from entering, and it's going to stop the pressure from getting any worse. Now, it's not going to make the pressure any better. You're essentially literally just putting a Band-Aid on the problem. You're stopping the pressure from getting any worse, but you're not stopping it from you're not making it get better. So what we're going to do is the treatment for this is occlusive dressing, and then we are going to start ventilating them. You are not treating the sucking chest wound if you are not using a BVM as well, right? We want to start providing them assistance with their ventilations. Besides these standard like halo or chest seals that you see, you also might hear about 3-sided dressings. You can make occlusive dressings with some like homemade materials. If you have a sheet of plastic that's sterile, so like, if you are running out of sucking chest wound treatment, if you're running out of occlusive dressings, you can take like a bandage package, take that sheet of plastic, put it over the wound, and tape 3 sides down, leaving one open. Essentially what's going to happen is somebody, when they take a deep breath in, the plastic is going to get sucked against the hole, so it's not letting any air in, but if they breathe out and any air escapes, there's a little burp hole for that air to escape. So it's not going to allow any air back in, but it does let air out. Really, any sort of sticky new thing we can put over these holes is going to help. It can be kind of drastic. There was a crew. So when I was at St. Mike's, I was pretty close with some of the UVM rescue kids. There was a very severe situation where essentially a student who was on quite a bit of LSD, like a lot of LSD, had a mental issue, and they essentially stabbed themselves 30 plus times in the chest with a fishing knife. So one of those like curved knives used to like gut fish. They just a whole bunch over their chest, and they just had dozens and dozens of sucking chest wounds. This was called in after the people in the dorm room below them called 911 because blood started falling from their ceiling, and UVM Rescue got there. We typically carry or like stock our ambulance with probably like 4 or 5 occlusive dressings, just standard. We really don't use these very much. They used them almost instantly, and then they used a roll of duct tape to just wrap around that person's chest because they ran out of occlusive dressings. Luckily, UVM is right at the hospital, so they managed to save this kid's life. But I was talking to one of them. He was in my EMT class, and he's like, we just had a roll of duct tape because we used all of our occlusive dressings. That was like 4 of the 30 holes they had. We had a roll of duct tape, so we just duct taped all the holes shut, wrapped them up like a mummy in duct tape, and they were fine. I mean, not totally fine, but the goal there is creating that barrier between the outside world and the air getting into their chest, because the more opportunity there is for pressure change, for the air getting in, the more likelihood that they're going to stop breathing. Now, I put this little note down here, the Volunteers documentary. If you are interested in seeing more treatments like this in a like documentary style, without blur or anything like that, seeing people treat combat injuries like sucking chest wounds, flail chests, doing needle decompressions, I highly recommend you watch it. It's on YouTube for free, last I checked. However, just like a disclaimer for you, it's pretty intense. It's about a guy who essentially volunteers to become a part of the first like medic squad for a rebellion fight in the Middle East. So essentially, these Western guys go and volunteer to help fight ISIS as non-combatants, as military medics for this, rebellion organization. I can't tell you that I agree with this guy's life choices or anything like that. That's not why I'm recommending the video. It is kind of an interesting watch. But in this category, he films everything, and you can see quite a bit of realistic treatment of sucking chest wounds, flail chests, needle decompressions, just basically combat medicine in an ambulance. So I recommend that if you're interested in seeing how this kind of works, how it looks, you can watch it. But again, it's a hard watch. Okay, so the other one here is a flail chest, also known as paradoxical movement. Do not be surprised if on your or during your psychomotor exam, they refer to it as paradoxical movement. You do have to know both. So again, this is when 2 or more ribs are broken in 2 or more places. And we're going to see when somebody takes a deep breath in, their chest will move in. And when someone breathes out, their chest will move out. Essentially opposite of what it's supposed to be doing because it has no structural integrity. So the main reason this ends up killing people is because of how painful it is for them to breathe. And essentially they are fighting to breathe. It's really hard for them to do so. It's really painful. And after a while, they essentially just lose their ability. They just run out of steam. They get too tired to continue breathing. So what we do is we can pad the area with bulky dressings to just stop any other potential damage happening to it. But then our main treatment is going to be splint by BVM. That's what we call it. So essentially, we're going to ventilate them. The main reason they're dying is because they're losing their respiratory drive. They're not able to do it anymore. So we can take it over for them. And their lungs should still be able to expand and have oxygen getting it put into their blood. But the challenge is how tricky it is for them to breathe. So if we do it for them, then we can help them a lot. Again, flail chest is the common term. Paradoxical movement is the other one. Just know that this is the same injury. So when we're doing our trauma assessments, that's when we say looking for equal bilateral chest rise and fall. If you see one side moving up and down, but you don't see the other, that's a pretty big indication that we want to cut that shirt right open and look for any injuries like a sucking chest wound or a flail chest. So the sucking chest wound and a damaged lung, can lead to a pneumothorax. Now, we can't necessarily fix this immediately. ALS can. A paramedic could fix a pneumo or a hemothorax very quickly with something called a needle decompression. So it's really going to be up to us, if we don't work on the same truck as a paramedic or a EMT, to recognize when we need to call for a paramedic to come and do this. So pneumothorax is the buildup of that air in the chest cavity, and it's going to be slowly compressing that lung on the, or both, on whatever side is affected. It can be built up to the point where we see that tension pneumothorax, where the trachea starts to move over because the pressure is now high enough where it's actually shifting the anatomy. And one of the big things for us and how we can assess for it, and what we're going to practice at Next Lab, is lung sounds. So we can use a stethoscope and listen to somebody's chest in the different areas of where we can hear their lungs. And we're basically assessing to see, can I hear air going in and out of their lungs everywhere? So I start on one side, I listen on the other. And then as I move down, if I stop hearing lung sounds on one side or both where they're supposed to be lung sounds, it could be that they're diminished. It could be that the lung at that point is not expanding, or it's like full of fluid or blood. So there's usually pain on the affected side, very marked difficulty breathing. They're going to say it hurts to breathe, or they feel like they can't catch a deep breath. Now, it can be caused by trauma, so like a blunt or penetrating injury to the chest, but I think I mentioned this before, it could also happen spontaneously. It's more common that this happens in like adolescent, tall, lanky white boys. That's kind of just the group of people that it affects the most. And usually it just happens spontaneously during puberty because they're growing too fast and their ligaments haven't caught up, essentially. And they can have just like a spontaneous pneumo. So oftentimes happens during like sports and things like that. So don't be surprised if you're called to like a basketball or a football game or whatever, and there's a kid with chest pain and difficulty breathing after being hit or, twisting really quickly. It could be a pneumothorax. So go ahead and listen to the lung sounds, call ALS, and get them to the hospital. What a paramedic can do in this situation, if it's necessary or if it's severe enough, is something called a needle decompression. It's actually really interesting to watch. They essentially take a needle that's about this long. It's a really big gauge. It's a 14 gauge needle. They've put it into the chest. They stick it through the rib cage, like in between the intercostal muscles, and then they open a valve. And it's really crazy. If you watch it, you put it in, you twist it, and then you hear like a balloon being let out as all the extra pressure exits through that needle. So then they turn off the valve. If you've got an occlusive dressing on and that is now closed, you've essentially fixed it, right? The extra pressure is out. There's no pressure building up anymore. And if all the pressure's out, the lung is expanded back to its normal size and the patients feel a lot better. Like you'll hear the, and you hear the patient go, oh, because their lung actually fully expands again. So it's really cool. Don't be afraid or don't hesitate to call ALS if you are picking up on the fact that somebody might have a pneumothorax, especially if you're seeing that tension pneumothorax. They need a decompression ASAP. So we did this on Saturday. We'll talk about splinting a little bit. And then we'll actually call it a night. I know we've talked about a lot already. Our next topics in this is going to be the big ones like shock and stuff. So we'll just save that for next time and get out a little bit early. So when we're assessing these injuries, again, coming back to the beginning of this lecture, we want to really assess the mechanism of injury. What caused the reason why we're here? What caused the injury? How suspicious am I that that person, based off of the mechanism, has a life-threatening injury? Of course, we're always going to do our ABCs, our scene safety, all that kind of good stuff. Our head-to-toe assessment, fix any life threats if there are any, putting on our BSI. But then if we've got like a specific injury, it's just a broken arm, we can do a focused physical exam. So let's say this kid down here broke his arm, no other concerns, not having any pain anywhere else, no life-threatening injuries, just a broken arm. We can spend a little bit of time actually assessing just that injury without worrying about other things. So we want to be very cautious. We don't want to cause them a good amount of pain, but we do want to have the best idea of what's going on. So what I was saying a little bit on Saturday is when we're assessing an injured extremity, we can start, if there's no obvious deformity, we can start up at the top, slowly palpate our way down, and when the patient says, ow, right, I'll move to the distal end. And when they say, ow, again, I know that the injury is right in here, between those 2 points where they said ow. It's somewhere in that area, so I can document that, and then I can focus my treatment, my splinting on it, right? There'd be a difference if they said ow over the elbow versus the radius and ulna, because my priorities when I'm splinting are going to be different. Remember, if it's a bone that's injured, we have to immobilize the joint above and below. And if it's a joint that's injured, we have to immobilize the bones above and below. So it's going to make it's going to make an important distinction for us in how we actually splint that injury. Of course, we're going to check those CSMs, the PCSMTs, before and after, checking for their pulse, their sensation. Can they feel you touching them? Can they move it? Are there any tingling sensations or numbness in their fingers or their toes? And then, of course, we can splint those injuries, keep them nice and immobile. Some last rules of thumb here for treating trauma. We're always pretty much going to treat for shock. If anybody has lost a lot of blood, if they've been in a major multi-system trauma, we have to assume that they're compensating, because compensating means that they're probably going to present a little bit normally, if not elevated. Their pulse is going to be high, their blood pressure might be normal, their respirate might be high, but that is all just telling us that their body is working extra hard to keep itself from falling off. So we want to support their body compensating, so always treat for shock. Now, life over limb is our goal. We would much rather save somebody's life even if it meant that they're going to lose their limb, either neurologically or physically. So that's why when I was talking about, the conversation that those medics had about an infield or out in the field amputation, the only reason we'd consider that is if we were worried that if we didn't get that person out of there right now, if we didn't get them unstuck, that they would die. We're always going to prioritize somebody's life over their legs, over their arms. Same thing with like a crush injury or things like that, and applying a tourniquet, right? Golden hour is the idea of from the moment somebody has a traumatic injury, they have about an hour to get to advanced life support, to get to the hospital and surgeons before it's essentially confirmed that they're going to die. It's around an hour people have from the moment they're hurt to when we can get to the hospital and have the best chance of saving them. So keep in mind where you practice, right? There are places in Vermont where it might take you half an hour to get to this patient. If they're out in the wilderness, it could take you even longer, right? So keep that in mind about how long you have, how quickly we need to be moving and getting them transported to the hospital. Good news for us, we do have some extra opportunities to do things like this. And in one of our lectures coming up, we're going to talk about calling for helicopters, like medevacs. We can do that. We have a lot of availability for that in the state. So we'll talk about that more in depth later, but keep that in mind. If you're going to be treating somebody out in the middle of nowhere and it's going to take you just like an hour to get from the patient to the hospital, you can call for a helicopter who can get them there much quicker. Okay. The other thing to talk about, and we can talk about this with medical conditions too, is we have to have the idea in our brain of what is best for this patient. Is this an issue that I can stay on scene and actually do something about? I can stay and play and treat them better? Or is this one of those situations where I'm out of my depths, I don't have the tools that I need a doctor, so we should load and go, right? So, like a broken arm, just a single isolated broken arm, that's a probably stay and play, right? Because I can make it better by splinting it, immobilizing it really effectively. I don't want to rush that splint. I can make sure it's best for the patient. We talk about how comfortable they are, get them pain control, and then bring them to the hospital, right, to get the bone set and casted. That's more of a stay and play versus somebody who's really injured, bleeding really badly. We're treating them for shock. That is a let's figure out their life threats, let's put a band-aid on it, and let's go to the hospital as quickly as we can. Prescribe diesel, right? Driver, step on it. Those are some of our considerations. Okay. Any questions?
A question and maybe like a short story and a question. So the one and only trauma call that I've been on so far was an avulsion. A an older woman, the dishwasher door, um, came down and it hit her shin, and she had like a 6 inch long avulsion that went right down to the bone. In this case, she and her partner were able to get the bleeding stopped. And when we got there, we didn't take the dressing off because it was stopped and we didn't want it to interrupt the clotting. My question is, in what situations, when we arrive and the bleeding has stopped, when or are there any situations where we should remove that dressing to inspect the wound?
I also have a bleeding question, kind of like what Michelle said. I had a call 2 weeks ago. It was for an uncontrollable bleed. And the guy, he had nicked a varicose vein. And when we showed up, he was sitting in the bathroom on the toilet, and the blood was like splattered all over the bathroom. Like it looked like arterial splatter everywhere on the wall, on the floor. Why was it so like sporadic? Like it was just like a crazy amount of blood for what he had did. I think he was in his late 30s, but he was definitely like a bigger guy. Um, and I know he had named some medications he was on, but they ended up, I mean, like we had brought tourniquets and stuff in because we weren't sure the extent, but it ended up just being like quick clot and gauze and bringing him up to the ED. Hmm. Yeah.
I had a question about the penetrating wounds in that picture you showed with the kid with the stick. How would you make sure that the object stays from moving? All right, thank you.